Good afternoon, everyone, and welcome to Masterminds today. I'm Melissa Wilkinson. I'd like to acknowledge the local custodians of the land in which we meet and honour elders past, present and emerging. I'm in the education team at the Hunter New England Central Coast Primary Health Network. I just want a little bit of housekeeping. Just a reminder about the survey poll. I strongly encourage you to please complete that. Today is being recorded and it will be in the education library to be able to view later. And also, questions box. If you have any questions, just pop those in as well. I'm going to hand over now to Kelsey. Thank you, Kelsey. Looking forward to this one. It's going to be really interesting.
Thanks, Mel, and good afternoon, everyone. And thanks for joining us today in this webinar around heart health and how you can use your data to drive patient care in your practice and identify patients at risk of cardiovascular disease. So I'd also just like to start off by acknowledging the traditional owners of the lands that we're all meeting on today. I'm coming to you from Awabakal lands, and I'd also like to pay my respects to the elders past, present and emerging. All right, so today we're going to go through a few things which you'll be able to see on the screen. So firstly, we're going to have a quick look at the prevalence of cardiovascular disease, just to give a little background and highlight the importance of assessing CVD risk. Then I'll introduce you to a cardiovascular report that's available to your practice through our PHN and run through what it can show and why it can be beneficial to you. We're then going to move through to looking at how you can use your data as a QI activity and how it can also assist to drive patient care. So this presentation will refer mostly to PenCat software or Cat4. So if this is unfamiliar to you or there's parts that you don't understand, please don't hesitate to put any questions through. And also feel free to let us know if you want to implement some of these strategies and that you're unsure of. If you just don't know how to use the software, just let us know because we can help you and support you with this. So just pop it in the questions. The principles around using your data will be very similar regardless of the software, but just a lot of the content in this presentation will be around the use of pen. I'll let you know as well that this presentation won't be providing any clinical advice around CVD, but rather our key focus is that we are looking at how you can identify your patients through your data and how your data can be used, which you can then take away and use to make clinical decisions from there within your scope of practice. All right. So to start off, the main theme of this presentation is learning how to use your data to identify cardiovascular risk within your practice. So I just wanted to quickly show you a few statistics available on the Heart Foundation website around the prevalence of cardiovascular disease and show why identifying cardiovascular risk can be so important. So I've included the links to these statistics in the slides on where they are on the Heart Foundation website. So you can have a look at another time and also access the references associated with the data. And as I mentioned earlier, we won't be discussing any of the clinical guidelines or advice. So I have included the links to the clinical guidelines, but you can refer to them later and use within your scope. So as you can see, cardiovascular disease is very prominent in Australia and affecting more than 4 million Australians and can cause 1 in 4 deaths. So the hospitalisation rates are also very high, and according to these statistics, 1 person every minute is admitted to hospital with CVD. So as you can see, early identification and prevention is so important and can make a big difference towards reducing the impact of CVD that it can have on the individuals and the healthcare system. So we'll look at how you can use the data to identify your patients at risk of CVD, and then you can assist them in treatment and prevention. So here at the Hunter New England and Central Coast PHN, we offer what we call a cardiovascular dashboard report. So you may already be familiar with the quarterly practice summary reports. So this one's very similar. However, rather than the larger report, this is just a one-page summary with a focus on CVD. So it can be used for a more targeted and focused approach. So on the screen here to the left is the sample report. It might be a little bit hard for you to see the exact numbers, but I'll run through what it has so you can see what's available. And just so you know, this is just a sample report as well. So all the data is as an example, and it doesn't actually reflect any actual practice data. So this report uses what we call the Framingham risk equation through the Penn software, and it determines a numerical probability of a cardiovascular event occurring in the next 5 years. So the link at the bottom of this slide, which you'll have access to after the presentation, it will take you to the Penn website, and it'll go into further detail about the algorithm that they use and how it's calculated in the software. So when we're looking at the report, if we start up in the top left-hand corner, the number in red is the number of active patients in your practice that will have some form of cardiovascular risk using that equation. So the number below that is the total active patients for your practice. So you can see in here with this data, there's 3,298 active patients in the practice. And of those, there are 1,922 patients at risk. So 58.3% of the practice's active patients. So if you move over to the right-hand corner of the report, the column graph will break down the level of risk for you. So it breaks it down into low, moderate, high, automatic high, and not calculated. So the Penn guides as well will go further into how that's determined, and it sits behind the algorithm and what their definitions are. But basically, automatic high risk means that the patient has a risk identified or a risk factor that makes them automatically high risk, regardless of what other factors you can put into the calculator. So an example of this will be like ethnicity. So if we then move down and we look at the blue table below the top section, this looks at the demographics of these patients, so age, gender, and whether the patients have identified as Aboriginal. So this will give a good indication on your practice's demographics. And as we know, this can vary drastically between practices, particularly with location and rural remote settings. The next set of graphs below the table look at what we call related conditions. So this means that the patient will also have a diagnosis of diabetes or CKD, their blood pressure recordings, and cholesterol. So just remembering when we're looking at these graphs, the data is for the red number at the top. So it's not your whole practice population. So for example, of the 1,922 patients at risk of cardiovascular disease, there are also 194 patients that also have a coded diagnosis for diabetes. So you may have other patients in your practice that have diabetes, but they haven't been identified as being at risk of CVD as well. So with the diabetes and chronic kidney disease graphs, you'll also notice that the grey bar in there has the word indicated. So what this means is that the software has identified something, whether it be a medication or a pathology result, that indicates the patient has either chronic kidney disease or diabetes. However, in the patient file, there isn't actually a coded diagnosis for this. So this is what we refer to as clinical coding. And in the Penn software, it's also known as data cleansing. So I'll touch on this a little bit later on as well. But just as the example, you can see with this graph for chronic kidney disease, there's 196 patients that the software thinks could have chronic kidney disease, but there's no diagnosis on that patient's file. So finally, if we just look at the 5 graphs down the bottom, they're all to do with modifiable risk factors. So there's waist measurement, smoking, alcohol, BMI, and physical activity. So again, remember when we're looking at these graphs, it's based on the red number at the top and not your whole practice. So when it says that there's 88% of patients with no waist measurement recorded, it's 88% of the 1,922, not the whole practice. But in saying that, we obviously want that number to be a lot higher and have it as recorded for as many patients as possible. So as you can see, this one-page summary can give you an overall picture and an idea of your practice population and where there might lie higher risk factors or specific patient populations you might want to target. So just as an example, if you were to look at this report, a few key areas that I might want to look into could be, the first one would be, I would probably look at increasing the recording and identification of the modifiable risk factors, like your lifestyle risk factors, particularly smoking, physical activity, BMI, and alcohol. You can see that there's quite a large grey area. So it's particularly important because we know that if we're identifying the risk factors in the system, it can obviously contribute to chronic disease. So I would also then have a look at patients that have diabetes and chronic kidney disease as well, and have a look at when they potentially last had a review, because the report's saying that they've also obviously got that diagnosis. So it creates another opportunity for point of care. The other thing that I would probably look at further is the indicated diagnosis list of chronic kidney disease and diabetes. And then another area I might focus on is ethnicity. So you can see on this sample here, there's 189 patients with no ethnicity recorded, which is super important because, as we know, ethnicity can be a risk factor for many chronic diseases. So it's really important that every patient has one recorded. There's also 195 patients that have identified as Aboriginal. So you could have a look at when these patients were last reviewed as well. So there's obviously so many things that you can look at and pull apart from the report, but that's just some examples on how you can have a look at it and pull out certain things you want to focus on. You can then use your pen software to create an identifiable patient list. So this here's just a little summary and some that we just touched on as well around the benefits of the report and why it would be beneficial to implement into the practice. So when utilised well, it can assist in creating better patient outcomes and improve patient care. It can assist in highlighting your patient demographics. It can provide focused care for your high-risk patients. It can assist in providing business models for the practice. It can help utilise your nurses and assist in driving your nurse-led care. It's evidence-based, and it can also show improvement trends or any other trend, whether it's decline or stable. And it can identify your First Nation population as well. And the other great thing is it summarizes your pen data for you into one page rather than pulling separate reports through your software. And then it can also contribute to your QI PIP, and it relates to the number 8 measure as well. So all these benefits as well is relevant not only to using the dashboard report, but to using any data similar to it in your software to help you identify those patients. This is also just a little summary on how we can use that practice data to then drive your patient care. And some of it we've already mentioned, but as I said before, once you've seen your report, it actually then allows you to then explore further and go into your pen software or other clinical software and analyze the data further. So for example, you can pull, as I mentioned before, the identifiable patient lists and then recall these patients in for a review. You can also look at cross-tabulation reports and look at things like treatment efficacy, which can be really good for GPs if they're wanting to look at that from a clinical perspective. You can look at missed opportunities and points of care. And then using all this information, you can look at then reviewing the patients as you see fit. So through either GP consults, health assessments, heart health checks, GP management plans, and so on. And it can also lead to multidisciplinary care. So it'll involve the nurses, and then you might be doing referrals to people like allied health and mental health support and so on. It's also a really great way to involve all of practice. So involving your admin, your front of house, management, nurses, and GPs as a team approach. So one important thing I wanted to touch on is when you're using your clinical data and analysing it, it will only ever be as good as and accurate as its origin. So what I mean by this is for the data to be accurate, it needs to be inputted properly and coded correctly from the beginning for the software to then pull accurate reports. So for example, if you are taking a patient's blood pressure and you're recording it in your notes, the blood pressure's been taken. However, if it's not put into the software in the right spot, or what is known as coding, then Pen and other softwares won't actually recognize that blood pressure in any reports that they pull. So if you wanted to do a report for your patients with a blood pressure of over, say, 160 systolic, the patient that you've put the blood pressure just in the notes, they won't actually appear in that search because their results are not coded. So they won't be recognized by the software. So this is also relevant to what I was discussing earlier in regards to indicated diagnosis. So if a patient doesn't have what we call a coded diagnosis, so for example, diabetes, they're also not going to show in any reports and searches. So if you wanted to bring up a list of patients for a particular GP, or you wanted to do your own list of patients that had diabetes, if the diagnosis isn't coded, they're not going to appear in that search. So it can be really important if you're wanting to use these reports and using the data to give you clinical information, because patients can get missed. And a common error in coding often stems from what we call free texting into the software. So I won't delve into it any further, but as I mentioned before, if you do want further information around or any resources around clinical coding, you can contact your PCIO or you can contact myself and we can assist you further and point you in the right direction. So the next bit I wanted to talk about is relating the data to a QI activity. So quality improvement activities are really important because it's something that the practice is working on that will contribute to better patient outcomes. So what I discuss with a lot of practices, particularly practice managers, is that a lot of what you do in practice is a quality improvement activity. You're already doing it because practices are constantly undertaking activities and focusing on areas for improvement to better your practice systems and patient care. So documenting these activities can really show and give a sense of achievement. And it can also assist in team morale because there's visual evidence in the team's achievement. Not only that, but documenting your quality improvement activities in practice is also a requirement for your QI PIP if you're participating in that, and it is a requirement for accreditation. So the screenshots on the screen at the moment is an example template on how you can document an activity using what we call a PDSA format or a Plan, Do, Study, Act. This is a really great format because it assists you from start to finish to think about what you want to achieve and how you may want to do this. It's also a great document because it helps in providing evidence around the activities. So did it work? Was there improvement? And what could have been done better? So again, our primary care improvement team here at the PHN have a lot of experience in QI activities. So if you do need support whether it's filling in this template or how to document your activity, just reach out and we can support you with that as well. Before I go into the example too much, I did just want to note that this is purely an example. So it should be used as a guide, and it can obviously be adapted. You can see there's obviously a lot of insert numbers here and things like that. Is that it's a template. So it can be adapted to suit practice needs, and obviously information can vary depending on individual circumstance. So this is just one way and one example of how you can take an activity that you've identified from your data or from your report that you wanted to work on, and then now transition it into a QA activity. So if we start on the left for this example, you can see that the overall goal for the practice is that we want to identify and reduce cardiovascular risk in patients. So from there, the next box goes on to discuss how you're going to measure it. And this is where your data becomes really important, because when you're working on something, you want to know that what you're doing is working or not working. So the data is really important, and your report, depending on what you choose to use, you can get the data at the beginning of the activity and use it as baseline data. And then you can get some data again at the end, and you should hopefully see an improvement or a decline. So then there's a summary of ideas and suggestions on how you might want to achieve the goal. So obviously there can be multiple ways that you can achieve the goal of reducing cardiovascular risk or identifying those patients. So it's a good way to sort of brainstorm different ways that you may want to achieve it. So for this particular one, I'm using the example for idea 1, which is using the absolute cardiovascular risk score tool to screen the patients, which will obviously assist in identifying cardiovascular risks. So from there, you know what you want to achieve, you know how you're going to measure it, you've got ideas on how you want to do it, and then now we want to actually look at implementing it. So this is where the plan, do, study, act part comes in on the right. So if we just move over to the screenshot on the right, we'll start with the plan bit. So the plan part just discusses the who, what, when, where, and how, and that can obviously vary depending on which idea that you're implementing. So you might want to have a whole of practice approach. It might be more of a clinical approach, so you're only using your clinical staff. It just really lays out the who, what, when, where, and how. The do or the did part of the PDSA is essentially the result or the plan. So what happened? Did you complete the activity? You could put, if there are any deviations from the plan. So for a lot of people, COVID has been a massive deviation from plans because it's affected many things, particularly face-to-face. So the study bit can be a bit more of an analysis of the activity. This is where you can look at what worked, what didn't, what data did you find. You can attach certain data. So if you're hoping to improve something by 10%, you might attach the actual percentage that you improved it by. And then the act bit is all about the what now. So what are you going to do moving forward? You might have identified things as part of this activity. It might be that you identify that staff needed training around how to use the clinical software. So you would then look at what you're going to do then to assist the practice moving forward. So this is just an example of a resource that we offer and what it can kind of look like. So this is, a lot of it is screenshots and examples. This one's directly related to that activity in the previous slide. So it's got to where you can actually find the tools that you needed for the activity. So the absolute cardiovascular risk tool, and it's got screenshots for best practice and medical director. And then on the other side, it's got where you can actually code things for the modifiable risk factors. So it's just a handy resource for people that might not quite know how to use the software. So that's pretty much a wrap on everything today. It has been a lot of information, and it could obviously have a lot more time spent on it, but it's just a quick session today. So what I wanted to show you before I do go is that we do have communities of practice through our PHN, and this is available to practices. So you can join these groups and be part of a group with other like-minded professionals. So on the right is the groups available, and one of these is obviously heart health. So if there was anything that sort of inspired you today, or you were curious about, you wanted more information or access to some of the resources that were sampled on the screen, you can email myself, so krolf@thepHN.com.au, or I've also added the link to our website, so you can go in there and have a look as well. And there's also, as I said, more information on the website around all the other groups.
Thanks so much, Kelsey. That was great. That was really informative. Thank you. A couple of questions have come in prior to the event, so I'll just read those out. Can you use the top bar to assist in identifying CVD risk?
Yes, absolutely. So top bar, for anyone that isn't aware, it is a software that goes hand in hand with PenCat. So top bar can assist you in all sorts of things. So it can help with identifying cardiovascular risks. A few examples is that it can identify patients that haven't got things recorded, such as those modifiable risk factors that we looked at. It can be really good for clinical coding and data cleansing, which we also touched on. And then it can also help in identifying patients eligible for a heart health check as well.
Great, thank you. And the last one was, how can you get the cardiovascular report for the practice?
Good question. So at the moment, probably the best way is just to get in touch with either myself, so from my email address before, or if you know who your local PCIO is, you can also get in touch with them and we can arrange for a report to be generated for you.
Fantastic, thank you so much. And just a reminder to everybody to please complete the survey at the end, and a copy of the presentation and recording will be in the coming days in the Education Library. Thank you, Kelsey, and thank you everyone for being with us.
Thanks,
See you
Mel.
next time. Bye.